Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers, producer of Public Health on Call. Today, we return to the topic of methadone access, this time to discuss some exciting regulatory updates. Dr. Yngvild Olsen, director of the Center for Substance Abuse Treatment at the Substance Abuse and Mental Health Services Administration, talks with me about new flexibilities in how methadone is prescribed and accessed, and how these updates, which came about because of the COVID-19 pandemic, are part of a larger cultural change towards making substance use treatment a more equitable, intuitive, and compassionate system. Let's listen. Dr. Yngvild Olsen, thank you so much for being on Public Health on Call. Today, we're talking about some new flexibility and regulations of how methadone is prescribed and accessed. And methadone treatment is highly effective, but we know it's stigmatized. It's often really difficult for patients to get. We're going to talk about those new regulations, but first, could you describe some of the challenges that have made methadone so inaccessible in the past?
Sure, and it's so great to be here. Methadone, as you said, is one of the most effective treatments that we have for opioid use disorder. But for many years, going back 50 years, one of the challenges was that you could only get it in opioid treatment programs, specially certified, accredited opioid treatment programs that had very rigid rules. And so for the most part, one of the biggest things there was that people had to go to the clinic almost daily to get their dose. And for many people where, they might live 2 to 3 hours away from the closest opioid treatment program, that was really hard. And it took almost a year, sometimes 2 years, for people to get to where they could actually take home between 14 and 28 days of medication. And so if you think about, trying to really kind of have a life, take care of kids, go to work, engage in, other recovery-related activities, that's really hard to do if what you're trying to plan around is having to go to the clinic almost every day.
In February, SAMHSA introduced the first major regulatory changes in 20 years. Can you talk us through some of those changes?
Yeah. So 2 of the biggest changes that we put into this, what's called a final rule, stem from some flexibilities that happened during COVID. Because as I mentioned, that for 50 years, it was really hard for people to get to an opioid treatment program almost on a daily basis for long periods of time. COVID really was the natural experiment that many people had advocated for over 30 years, where really to keep both patients and providers, the staff that were working in OTP, safe, that the federal government made 2 really big changes. So one was that no longer do people have to come into the clinic every day to get their medicine. People could actually take anywhere between 14 to 28 days of medication home. That not only from anecdotal experience over the past 4 years, but also research that was done on the implementation of that and the outcomes of that really showed that this expansion of access to methadone take-homes was met with positive responses, both from patients and providers, and that it was not associated with any significant increases in diversion and misuse or methadone-related mortality, as had been feared, and really was the reason why those changes had never been able to be made prior to that. So in that final rule that we released in February, we made those flexibilities permanent. So now people don't have to go to the clinic every single day to get their medication when that is, a decision that then kind of is made between the patient and their provider. So that was kind of one big one. The second flexibility was put into place under COVID was being able to start buprenorphine through telehealth, including audio only, in an opioid treatment program. So that really made access to buprenorphine through an OTP much more accessible for individuals. And that also, not only through anecdotal experience, but also research, has been found to be safe and effective. And so we also included that as a major component of the new rule. In addition to that, and I would encourage people to really go online and look at our website to look at all the different changes, because we've made a lot. The other thing that we really wanted to make sure of was that for a long time, OTPs have operated in, and this is a generalization, and so there are exceptions, but in many instances, the OTPs have operated kind of with a more punitive approach to not only take homes, but people who have substance use disorders. And so people haven't really wanted to access services in them, even though the compilation of services really is pretty tremendous and can be not only life-saving, but also support people in their recovery goals. We have really tried to infuse person-centered care, non-stigmatizing language, really trying to change the culture of OTPs through the regulations so that shared decision-making between the patient and the practitioner, really making sure that this is a safe place to go, that this is effective, and that the services are flexible and, really provided in a trauma-informed and a strengths-based way.
So people are able to initiate care through telehealth. They can go less often and take home more medication to stay on their program without the added stress of a daily visit. And then when they are there, they're getting better trauma-informed treatment. They're being taken care of holistically. These are really big changes. How have you seen some of these things playing out?
Yeah, they are really huge changes. And, this is the first substantive change that has happened in these OTP regulations for over 20 years. It's been really heartening to kind of hear that we've had outreach from individuals. Like heard one story of a gentleman who he had been on methadone in an OTP previously, but had dropped out because it was just hard for him to have to go every day. He now was going to go back because he knew that it worked for him. He was still struggling with his opiate use disorder, but now said, now I can actually really imagine being able to go and get my medication and still, go about my work. We heard another story from an OTP medical director in the Northeast who said that she had just done an admission on a patient who had had an opiate use disorder for 20 years, had never been in treatment, and he was now coming for the first time. And when she asked him why, he said, "Oh, because I heard that I don't have to come every day. And now that actually is going to work for me because now I can get my treatment and take my medication and engage in other services, but I don't have to completely turn my life around to try and get here every day." I think we're really trying very hard to help people get access to not only a life-saving medication, but then all the harm reduction services and recovery support services and a compilation of services that really is taking a whole person approach so that people then can go about their lives and really go about their lives in recovery.
There are a lot of opioid treatment programs. I mean, have you seen uptake of these changes across most of these clinics? Do you have a sense of how many are actually implementing these?
Yeah, so the effective date was April 2nd of 2024. So that means that that's the first date on which OTPs can start to implement these changes. The compliance date is October 2nd of 2024. And so that's the date on which, OTPs then need to come into compliance. This is a little bit of a complicated system because we at the federal level can set these standards for care in opiate treatment programs. There also are accreditation bodies that then accredit the OTPs. And so we're working with them on what that means for their accreditation standards. There also are states and state rules and regulations that also come into play. And so we anticipate that as we're working with states also then need to just look at their own regulations and their own rules to make decisions about how they want to align with the federal rules now. But I do think that there are some things that, even short of those pieces, that really meeting people where they are, treating people with dignity and respect and kindness, and really that trauma-informed, non-stigmatizing approach, that's something that we can do from the get-go. We don't need changes in state regulations or accrediting standards in order to be able to do that, because that's part of this culture change is really just we want to treat people with kindness.
And all of this is what you're describing as a culture change. And it's going to take time, as you said, to implement. And it's going to take time to know what sort of the uptake is among people with substance use disorders. How do you think this is going to stack up against what is really needed to push back against the opioid epidemic?
That's a great question. Certainly, opioid treatment programs, they are a critical part of the specialty addiction treatment system in this country, one in which they play a crucial role in really helping to provide life-saving treatment and services. They are one part. So we also know that we need the whole healthcare system to really be able to step up, whether that be in hospital emergency departments, in hospital inpatient settings, in primary care settings, cross specialty settings, and other settings, whether that be in schools or correctional settings. Substance use disorders is one of those things that between prevention, harm reduction, treatment, and recovery supports across that continuum, it really touches so many different parts and so many different sectors of our society. So we really need all of those sectors to be part of the solution. I think the other piece is that from a healthcare perspective, that substance use disorders also have been one of the most stigmatized conditions. And that stigma also sometimes relates to the medications that we use to treat opioid use disorder, including methadone and buprenorphine. So I think my other hope with these changes, and I think kind of the other vision that we had was that really with these changes that we hope to further the conversation around the use of methadone, around the treatment of opioid use disorders, and thus also help reduce that stigma.
And we've seen expansions in other ways, for example, in correctional facilities and treating pregnant people. What else do you think would make a big difference towards helping this culture change really start to have more forward momentum?
I think there are two things. One is that it wasn't, and I'll just give you a little bit of an anecdote. Like when I was a resident, one of the best rotations that I did was actually spending time in an opioid treatment program in Boston. And I saw that people who were taking methadone were in recovery. There was a gentleman who had been on methadone for 20 years, but he had his own business. He had bought his own home. He had remarried and had a great family. And so people who take methadone can and often achieve recovery, and helping to sustain that and kind of being with them the ups and downs of what we know is a chronic disease is incredibly, incredibly rewarding. And I think understanding and having not only healthcare professionals, but family members and community members and the public really understand that, and that methadone is an incredibly effective medication, and that we really need to meet people where they are on this long trajectory of that chronic illness. So that's kind of one thing. I think the other thing is that really being able to take advantage of some of the provisions that we've made. So you mentioned correctional settings. So one of the other changes that we made in the rule is that for correctional settings where individuals may have a primary condition that is something other than an opioid use disorder, and that correctional setting has a designation from the DEA as a hospital/clinic, that correctional setting can continue or start people on methadone without having to be an opioid treatment program. So, really being able to then have people continue their medication or start that medication to reduce the risk of overdose that we know is incredibly high when people then are released from those carceral settings. So that's kind of another example of one of the big changes that I think will need to help with technical assistance and training, and also then monitor how that gets implemented. But that's another, I think, example of how these new changes could potentially have significant impacts on people's lives and on communities.
I really appreciate you sharing that anecdote, because I know those first person stories are part of what helped many of these changes take root in the first place. So I'm sure you're hoping that centering people's experiences will continue to help make these changes to make it more and more accessible.
Absolutely. And I think that's what I've seen over the years is that when people actually put a personal story behind what sometimes are seen as that sometimes are misperceptions and myths of what methadone is or isn't and what it does or doesn't do. I think those personal stories, and when people actually see that, oh yeah, no, absolutely, people can and do get better. And that methadone is a medication like many other medications that we have that needs to be monitored. And, people we need to talk to people, and check up with them. And it's part of a treatment plan and a care plan.
This is all really positive, and these are major changes. And I know that you're looking forward to seeing how they play out. So what's next?
Yeah, so we're going to continue to work with the accrediting bodies, with states, with the OTPs themselves, with other professional associations, with people with lived experience and people who are beneficiaries of, and hopefully the beneficiaries of these changes. We're going to really continue to keep working with them towards that compliance date, but then even beyond, because this is an opportunity we really want to see have come to fruition.
Dr. Yngvild Olsen, thank you so much for being on Public Health on Call.
Great, thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.